Boa tarde a todos. If you can, I can have the slides, please. So I will switch to English. We will discuss in the next minutes, next hour, about tricuspid valve therapy again. So I will be the anchor person, Adolfo Ferreiro, the spokesperson, and Márcio Montenegro from Brazil, from Rio. You are in your place now.
Thanks,
we will discuss with us. And we have a lot of things to debate here. My name is Cristiano. So these are the session objectives: to demonstrate through a TricValve implantation how tricuspid regurgitation can be treated using a minimalist approach. And Adolfo will show us a case, and we can discuss in clinical practice how we do that. To present the TricValve clinical evidence showing the impact on hospitalization rates and quality of life in patients with tricuspid regurgitation. And to highlight the data showing the effect in right heart chamber dimensions and the hemodynamic changes. So we have things to do here. I'll discuss a lot. So let's start. So this is the clinical scenario. This is our patient with right heart failure, jugular distension, ascites, limb inferior edema. We have a torrential TR, as you can see in the echo. We are always concerned about the RV function, and you can see that in the MR. We are concerned about the hemodynamics and especially the pulmonary artery hypertension. So we have to deal with all that information and choose the right treatment for our patient. So this is the severe TR treatment algorithm, one of the algorithms we have. We have think about the left ventricular disease, about the surgical risk of the patient, and see the coaptation gap, if the patient has pacemaker, if the patient can use anticoagulants, and choice if the patient go to surgery, to TEER, to orthotopic implant, or to heterotopic implant. So in the next hour, we will discuss the heterotopic implant with details. This is the anatomy, but Adolfo will treat that in the next minutes. So we can go straight ahead to Adolfo to see the case and discuss all that.
Thank you very much, Cristiano. It's a recording
Hello,
case.
morning. It's a pleasure for me and for our team to be here presenting this amazing case. It's amazing because it's going to be the first non-contrast cavity done with a TricValve system and recorded for an important congress like RIO VALVES is. Thank you for all the organization, PFM, to allow me, my team, and the National Institute of Cardiac Surgery in Montevideo, Uruguay to record this case for you. We want to try to make it very educative. These are our conflict of interest. The case is related to a 65-year-old lady. It's totally inoperable with a torrential TR that is secondary to the left side her valve disease and a tricuspid valve reparation failure, a segmentary annuloplasty plus pacemaker lead across the tricuspid leaflets. The surgery was done in 2023 due to mitral valve disease, severe mitral stenosis, and moderate mitral regurgitation, and the severe TR. The operation was a mitral replacement with a mechanical valve and a mitral and a tricuspid reparation with this annuloplasty segmentary. The other relevant medical condition you can see is a very sick patient with a tachycardic arthritis, smoker with a moderate COPD, Crohn's disease, coronary artery disease with the circumflex occluded totally and chronically, hypertension, renal failure with a clearance of creatinine less than 15, immunodeficiency with a chronic use of corticosteroids, and this pacemaker after the surgery due to a 3-degree AV block. You could see here the left ventricular ejection fraction is borderline or even a little less. And you see here the pacemaker leads across the mitral. Hello, good morning. It's a pleasure for me for cross-step tricuspid reparation with this annuloplasty segmentary. Occluded totally less ventricular ejection fraction is borderline or even a little less. You see here the pacemaker leads across the mitral, the tricuspid valve, sorry, and the lack of coarctation, and you see here the torrential TR. Regarding to the right heart catheterization, you can see that the central venous pressure is around 15. The pulmonary artery pressure is around 50 with a mean pressure of 30, and the weight is around 15. Doing some math, you can have a cardiac output of 4 liters and a right ventricle to pulmonary artery coupling of 0.35 due to a total of 18 plus 50 of pulmonary artery pressure. If you calculate the T-score, you are going to get that the risk of the surgery is very high. And this score has not in consideration that the patient is low weight and also has chronic use of corticosteroid. Regarding to the CT analysis, you see that the superior vena cava have a lot of measures. We think that the best node and the one that we have in account the most is at the level of the pulmonary artery, and it's around 19. The distance between the innominate veins and the bifurcation to the entrance of the atrium. So with all these measures, we decided that 25 superior system is okay for our patient. Regarding to the inferior vena cava, you see the inferior vena cava in the entrance of the atrium is around 30, and all the other measure is even less. So we know that we can use a 31 system for inferior vena cava, having a good sealing and also a stable device. The team in the cath lab is going to be Alfredo Fiandra, Luciano Giovanni, written by me, and well, we'll go together to the cath lab. Thank you.
Recording this precise case for you, which is very important for us because we are going to show you a case.
Just to discuss a little bit. So this is a really patient to daily clinical practice. A patient with left and right valvular disease, and you treated first the left side surgical. And
Both. Also the tricuspid.
Also
Both
tricuspid.
reparated, but it failed.
Yes, but now the patient is evolving bad, and now we have a torrential TR with a lead, a pacemaker lead, and you did the right heart catheterization, and the patient has no contraindications to go ahead with a tricuspid procedure.
No,
But why you analyze go with a heterotopic implant? What are your thoughts about that?
We follow somehow the algorithm that you show. It was TR was impossible. The valve was deformated because of the pacemaker, and also it has a reparation. And well, the level of coarctation, the degree of the disease of the leaflet was tremendous. So no chances for TR. We also evaluate the patient for looks, and she has a very angulated venous cava with the right ventricle. So it was an skin failure also for lux valve. So the solution we have was the TricValve. And no contraindication, sorry. We have into account when you have a very sick right ventricle, the pulmonary resistance, and also the ventricular arterial coupling. It was 35 was okay. So we decided that she was a candidate.
Yes. So it's a very common situation. We have now many devices, but we have many contraindications, or not possible to do TR, to do orthotopic implant, and
Screen failure.
we have to see, yes, screen failure. So we have to more options to do this treatment. So go ahead, Adolfo. It's okay.
Marcio?
Yeah.
Something to comment?
Yeah. It's really interesting. Thank you for bringing this case because it's a real-world patient. So first, I need to understand what kind of TR it is, because probably it was a functional. But now, what's the whole of the pacemaker in this scenario? The patient is worse after the pacemaker because you can put the lead above the septal leaflet. And second is, if you attended today the session, the tricuspid session,
yeah.
Now we have, it's very interesting because we have more information in how we can talk about together. First, the right ventricle pulmonary artery coupling.
Yes.
So this is a very, very good information. So this patient has a 0.36 coupling. So we say that when the RVPA coupling is below 0.25, we call this uncoupling. So this patient probably you cannot treat him because there is no effect to your treatment. Probably it will be a futile treatment. Mm. And there is a paper recently showing us that if you have a 0.30, you cannot treat it, you cannot do surgery in this kind of patient. So we are starting to have some information that you didn't have in the past. And second is the Tri-score. Tri-score is very nice, mainly because we split the patient and the patient's low risk, intermediate, and high risk. So we can say this patient is a high-risk patient. In the past, it's not possible. So for a while, you have two good informations to indicate the procedure. It's very nice. Yes. And you are following the right line to decide the best treatment for this patient.
Yes, and you are all concerned about the RV function. So if you close the tricuspid in the valve, the patient can...
probably you have RV failure yes. After the implant.
And if you have the right atrium like a compliance chamber, you can do more chance to this post-operatory period. So
yes, because this kind of solution, you have a right atrium like a reservatory. Yes. So what we thought in the past that the ventricularization of the atrium was bad. It's not too bad. It could be good for the patient.
So,
yeah, the more ventricularization you have, the better the ventricle is.
TricValve done without contrast. We are going to guide the procedure by echo, and one reference in the pulmonary artery is going to be a pigtail, and while deploying the inferior vena cava system, we are going to have two catheters in both hepatic veins. So we are going to guide the procedure without any contrast. It's a pleasure to me to share this case with Alfredo Piandra. We are going to show you a picture of him and Luciana Giovanni. We are part of the structural heart team. We are sharing this case with a couple of interventional echocardiographers and our anesthesiologist. Here we have the pleasure to have Leo and Paula from EFM. They are preparing the system for us. We are going to show you all systems while implanting them. And, well, the setting that we have today is we have two left groin axis and one right that is going to be for the valve deployment. The two in the left, one is for the pulmonary artery and the other is going to be for the left hepatic vein. So we have the catheter in place. We are going to show you a setting now. You can see the patient has a mitral valve. It is a mechanical one. some pacemaker leads and our catheter. That's the structure that we want to have in the heart. So now we are going to put the catheter in the tubular vein, the right one, sorry, to deploy the valve. So we are going to advance first a regular shade wire, and then we are going to put there a quite stiff wire that we normally use for these cases. It's called shade wire, and it's really stiff. So you can try to take a look. It's a very stiff one. We have our catheter in place. So guardamos la wire there. While removing the catheter, I'm going to show you. The first system that we are going to use. Please come here with the camera. We have two systems, superior and inferior. You can see that both are very similar. If you take a look at, they are 28 French in size, and you have a very little noun stone, then the capsule that contains it all, and the system. The way that you are going to release the valve, we are going to show you perfectly that is by moving this scroll one, the red scroll, turning it clockwise, and then you have a sort of lock to try to recapture the noton while you when you finish to use it. It's quite similar with the other system. The mechanism is quite similar. We are going to start with the superior vena cava system, and before to do that, we are going to predilate the groin with the 16 or 18 French sieve.
So, Adolfo, two venous punctures. The wide is like a
to remove the sheet, and we are going to come. Yes. Take a look at
a really stiff
the
wide.
system again.
From Shotec, and it's called shade wire. It's like a lander piece. It's
Lander
like
piece.
Siemens lander piece, exactly.
Yeah.
A straight one.
And you have a fork for the air in the system, and to hydrate, we strongly recommend you to turn the device a little to enter the groin, because it is quite bulky, and the transition is not that smooth. Really. So we turn the system, then when we are in the vein, normally everything begins. So we are going to hold the wire. Let's take a look here. Slowly pull out. Good. That's perfect. That's perfect. Let's record it, and you can see now we are with the device in the top of the pulmonary artery where our picture is. So we are perfect to start the release. So you can see that.
What do you think about this position, Marcio? Huh?
Yeah, I think that you will not do a shot of contrast.
Zero.
Zero?
Zero, 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 zero.
Yeah. Nice. Yes, I think that
No fusion. Huh?
Yeah.
So just the catheter.
Yes, the only concern here if it's your pigtail is the right place, not in the inferior branch, you know, because sometimes you can, some confusion in your position.
Yeah.
But if it's the right place, it's exactly in the point exactly, because you can put the pigtail in this depression below the belly after the release. So you must try to keep this position at the end. It should be nice.
So it's a good point to start. If you see, the device has a belly that now is closed,
Yes.
but you see a small wrist that is just above the catheter. That is the right place to develop the device.
In the middle part, a little below the middle part, you see the worst. This is below the belly of the system. So this is the real mark that we have to use to put the system just above the pulmonary artery, avoiding any artery compression, external compression. So we have the catheter there for angiography wire and also to check the pressure. So we're going to start to releasing the system by this. Just scrolling. So it's a long way. So we have to be patient. It's not for anxious people. And you're going to see that I am holding the system while Luciana is unscrolling the system. And also, I am putting it back. Because while you are unscrolling, the system is releasing and going in. So cranial,
can see very
it tries
stable,
to
huh?
goes in. So we have to correct this
Very
this
slowly release, stable
tendency.
device. It's very nice.
by putting the system back. So our eyes are located in this worst. We want this worst to be in the top of the pixel and to release the system like we are doing. And you see, I am correcting from time to time. Now you are going to see that the device is curtain opening, the upper crown, perfectly smooth. I am correct about to deliver the system. We are like in 70% of the releasing, so we are okay. Now we are like in the 90% of the releasing part, so we can now go back. And now we are going to release scroll by scroll, because we want a very controlled releasing. Perfect. Valve is absolutely that is release it. So we are gonna pay attention. One thing you can see below the upper crown, there is a worst that is bigger than the nose scope. So we are gonna have pretty much space to move the device back. So we are going to keep the wire in position. No, the valve is not. Sensor depleted, sorry. So the intention is to go into the right atrium or the vena cava to recapture the system.
Right place.
We are
Perfect
perfectly
implant. Yes.
there now. So we are what to unlock the system. You see, the unlock is like this. So you have to move the system and then you unlock. And now we are going to release it by holding this red mark and to pull the system back. Perfect. The wire is absolutely in position, so we are conditioned to. Perfect. We are ready to advance the inferior vena cava system. Wire is positioned, so we are going to advance the system to the inferior vena cava, and we are going to move the pigtail that we have in the pulmonary artery to the right hepatic vein. Perfect. So we have our two markers. So having the pigtails as a reference, we're going to advance the system, and we are going to start checking it by echo. So at the beginning, when you have the valve into the capsule, difficult to know exactly the height that you have inside the right atrium. So we have to release somehow the valve, let's say like 20% after flaring the valve, you start seeing it in echo. So the second part is going to be the position of this like a skirt, like a V shape in the right atrium, and to try to measure the distance that we have between the roots of the right atrium and the system. So when we are happy with that, we start to deploying and checking and checking. Well, now we are happy with our reference, so we are going to start releasing the valve. So we unscroll it clockwise, and the other device, you have to be patient. It's quite long, the releasing, but it's very controlled. They're very happy with us. So we are gonna wait for the flaring, and then we are gonna take a look at the echo, how deep we are in the A2. Our target is to be somehow some point between 8 and 10 millimeters inside. It's gonna be our sweet point. The valve dive in while we are unscrolling it. So I am pulling back the system to correct the position. Opening. A little more, a little more. Perfect. Now we are gonna try to insert the parallax of the valve. So we now have the parallax. Perfect. We think that we are in position, geographically speaking at least, and we are gonna check it now on the echo. So
the images in echo are not perfect because of the COPD, so we try to make some graphic things here, because normally we are not well trained in echo. So the anatomy is like this. So you have the hepatic veins and the right atrium, sorry. Normally the imaging that we get is like this. What we try to do is, when you have the device here and it is closed, you normally don't have a good images on echo. You see something, you don't recognize if you are taking a look at the non-scope of the valve, or the valve, sorry. So you need some flaring, you need the valve to be like this to see on echo. And then what we try to take a look at is the distance that we have from the floor of the right atrium to the top of the device. It has to be more or less between, let's say, 8 and 12. So if your echo guy says your device is clear, close to this distance, to this millimeters, you are more or less okay. So sorry for the drawing, but it's more clear than the echo that we get during the procedure at this time.
The window we normally use subxifoid, and we try to take a look at the entrance of the hepatic vein in the atrium. So this is the perfect. We are good in position. Probably we can start releasing a little more. Normally try to correct the parallax. Perfect. We're going to continue releasing and then to start checking leakage. Now it's only the position. It's the important part. Now we are happy with the ancho, we are happy with the echo, no leakage, almost. The pressure is more or less okay. Sometimes we have P waves, and we think that it depends on the position of the catheter, interfering the valve closing. Perfectly in position, and we are releasing the valve very slow. Stop there. I will remove the catheters.
So until now,
Then
zero
I
contrast.
release the last one.
Absolutely zero contrast.
Are sort of
Yes.
paddle. I'm happy now with the V-wave pressure
So
in the
pressure,
inferior system.
angio, and echo.
Now
It is very
it
important
is
for us.
absolutely released. Hopefully with the non-scone. And then in the inferior vena cava, we are gonna recapture the system previous to
Can you
releasing
pause?
it.
Just this is a very
Perfect.
important. This is a very important step. You show it very well. Very slow deployment, especially in the inferior vena cava valve, and in the end, relieve the tension because the valve can jump to
jump
the right
slightly,
atrium.
yes.
So this is
Yeah.
a really, really important step. Slow and relieve the tension.
Because if you have a lot of tension, you don't realize exactly where you are.
Exactly.
Yeah.
The final position is going to be the truth. So you need to release the tension, but you need to release the tension at the very end of the device.
Yes.
Otherwise, it always tries to go in.
Yes.
We capture it.
You see here, we are taking a look, of course, at the ceiling of the device, but at the distance that we get from the floor of the right atrium to the top of the device. We are happy with the position. So
We are going to remove any interference on the valve system. Yep. And we are going to check in the echo our final result. We are very, very happy with the pressure, with the angio, with the position, and with the echo also. We have more leakage in the right part.
Perfect.
Well, as a summarize, we would like to say thank you again to PFM and RIO VALVES for this opportunity to show this amazing case, a very sick patient that she received a cavity, and without a dot of contrast, it is a totally proof of concept, and you could see that it was very smooth, and it is a perfect result. You will see here how we started with the vena cava pressure. The mean pressure was 23. The V-wave.
take a look at this big wave. It
Yeah.
was 23, 25. You know, depends on the ventilation, the respiration. She was on air, and how we get at the end of the procedure, the normal PVC.
Was 23, and it went down to 16, proving that the system is closing and protecting the venous system from high pressure. And you could see this imaging worth a fortune, because you could see the ventricularization of the right atrial pressure when the system is working properly, and you will see this is not ventricularized because of the catheter is interfering with the valve closing. So you see the ventricularization of the right atrium, and without.
That's imaging. I love this imaging because we had the wire inside. So with the ventilation, probably the wire interfering in the properly closing of the valve. So you see the valve functioning, non-functioning, functioning, non-functioning. It's perfect. You see the difference, the ventricularization, and you can understand easily what's going on when the valve is closing. So the ventricle is forcing to increase the cardiac output.
The system working properly, how it decrease. So it is important to understand how the system work, and this is a very clear hemodynamic that shows how it work. Thanks again.
So perfect, Adolfo. I think it's something you have to consider. Very sick patient, local anesthesia, sedation, mild sedation, transthoracic echo, no contrast, and a procedure that we showed in few minutes here in this place. So
It's absolutely like this. You can guide the procedure. Of course, if you have fusion imaging, you can use it
Yep.
because it's close to the reality. But having the catheters there, you know exactly where is your anatomy when the patient is ventilating, when is during the respiration. So it's a new proof of concept. So you arrive to a place, we face this situation. Oh, the echo does, or I don't know, something went wrong. If you have the catheters inside, you can do the procedure in a very safe way.
Yeah. So I think the minimalist approach is something to this kind of patient, but we want to see the data.
Yep.
So Márcio, you can show us, please.
Yes. First, congratulations, Adolfo, for bringing us this terrific case, a free contrast. It's really impressive with the final result. So the next minute, I'm going to share with you tricuspid breakthroughs, better outcomes are possible. This is my conflict. So it's important to understand, look at the burden of the tricuspid regurgitation in comparison with aortic stenosis in this registry from Bronx. It's really impressive how much patient we have with tricuspid disease. So it's really a disease that you cannot forget anymore. And the impact of tricuspid regurgitation, long-term survival, is not only for the severe TR. You can see the moderate TR that the survival is less than the patient that presents no TR or mild TR. And when we see another solutions, more the contemporary solutions at the end of a year, like the triluminate 1 year outcome, if you see at the end, at 30 days, it's possible to see also, but at 1 year, we can see that half of the patient has some grades of TR, and if you remember that this kind of patient, the survival is less. So it's important to see that sometimes it's not to maintain the results at the end of 12 months of follow-up. The good news is the new guidelines from the European Society has changed for some indication, and it's included the heterotopic transcatheter valve replacement. And when we see this fluxogram, you see that the most important is at the left side. When we see, because at the right side, it's okay. At the left side, when we see the patient with a severe TR, primary or secondary, doesn't matter, but with severe RVLV dysfunction or severe precapilar pulmonary hypertension. If not, the next question, if it's symptomatic, if yes, go to the appropriate surgery according to the heart team. But if the patient is no, the answer is no, and the patient is asymptomatic, the next question is RV dilation or RV functional deterioration. So if yes, you can go to the appropriate for surgery according to the heart team. So we are thinking now to treat this patient that we say they are asymptomatic, because if we waiting for this, we wait for the symptoms, maybe it's too late to start the treatment. Then I'm going to show you some TricValve clinical evidence. The last paper just published was the TricValve registry. We know that it's a registry, but the TricValve study is a real-world investigator-initiated in a multi-center registry that retrospectively and consecutively included more than 200 patients from 27 hospitals. The indication was all patients with symptomatic severe massive torrential TR who were deemed to be a high surgical risk. The tricuspid regurgitation treatment made easy. It's a easier treatment comparison with other kinds of solution, even TTR or orthotopic prosthesis. And you can see two independent mechanisms to control the right ventricle backflow in the SVC and the IVC, compatible with pre-existing pacemaker. Right atrium acting as a reservoir, not like, as we said before, maybe it's not bad, it can be good.
No, especially in this patient with very bad right ventricle, because I think that this has to be the difference, because with the bad right ventricle, you close the way to go back to the blood.
Yes.
And it's the end, because the ventricle has to do all the work forward and not backward. So probably this reservoir is something that is good
Yes.
for especially this patient. No?
Yes. No touch the native valve. We can think that to treat the valve further. Recover right ventricular pressure and joint work of atrium and ventricle. Possibility of multiple future heart interventions, it's possible. And minimally invasive procedure with the possibility of conscious sedation, and now with free contrast. This registry, as I said, 27 hospitals with more than 200 patients. We were in our institute the only hospital in the America that has participated in this study. As you can see here, the right heart failure due to severe TR, inoperable and unsuitable for transcatheter orthotopic repair or replacement. Rejected for CAVI when the TAPS is below 13 and the LVEF below 40% and the pulmonary systolic pressure above 65 and the V-wave below 15 millimeters. And for sure, the patient needs to be suitable, anatomy suitable to the bicaval. When we see the baseline characteristics, I'm going to show your attention to the TRI-score. The TRI-score, we see the high risk was almost the half of the patient, 45% of the patient, and 36% of the patient was intermediate. So the patient was really, really high risk. Half of the patient had a prior cardiac surgery, and the hospitalization by heart failure in the past year was 60% before the procedure. The result has shown us in hospital mortality 8.3% and a significant leak not treated 2%. 12%. So with a high implant success, 96.1, and it's very good when we compare with another kind of treatment of the tricuspid. And when we split the TRI-score, we see that the patient for sure that has low risk, the follow-up is better when in comparison all cause of mortality. But it's important to understand that the TRI-score is in hospital mortality, not at the end of 12 months, a year. So even when compare, we see low risk is until 3, would be 5% in hospital, and at the end of 12 months, we see 6.7%, as we can see here, and it's a good result in a group of high-risk patients. Some another data, the patient presented reduced signs of right heart failure and heart failure hospitalization. When you compare before the procedure, the heart failure hospitalization was 60%, and after 12 months, dropped down to 26.9. The signs of right failure, edema or ascites, go to 73 to 22, the edema, and the ascites from 31 to 4.9. So, so impactant after implants of the TricValve. The improvements in hemodynamic status and functional class is observed also. We can see before the treatment, almost 80% of the patient was in functional class 3 and 4, and after 12 months, it's almost 8% was in the functional class 1 and 2. The impacts on hemodynamic parameters, as Adolfo has shown us in his case, we can see the increase of the RA mean pressure after 30 days, but after 12 months, we see a decrease again, the pressure, and IVC a decrease, and IVC V-wave also. So there is a good impact on the hemodynamic status and functional class. The echo at 1 month and 12-month follow-up, we can see it's very interesting to see this a good remodeling of the right ventricle. We can see at 1 month from 52 to 50 with impact statistically, and even if not impact, but it's there is a decrease of the size of the right ventricle. But if you see the number of the patient were lost during the follow-up, start with 174 and 12 months it's only 73. So probably this is the reason why we don't have statistical impact in this data. And hepatic vein systolic flow reversal also has diminished for after the procedure. Then we have some red flags in this kind of patient. There are New York Heart Association 4 functional class, renal dysfunction, hepatic dysfunction, TAPS below 12, were independent predictors of in-hospital mortality in a multivariate analysis. The patients followed for 1 year demonstrated baseline versus TricValve, fourfold improvement in New York Heart Association functional class 1 or 2, threefold significant reduction in peripheral congestion, sixfold significant reduction in ascites, fourfold significant reduction in diuretic doses, twofold significant reduction in hospitalization rates, eightfold significant reduction in hepatic vein systolic flow reversal. So the heterotopic treatment, it's a solution. As I said earlier today, we are not trying to fix the valve. We are trying to fix the hemodynamic of the patient. Yeah. We're organizing the flow, tackle the backflow. The problem of this kind of the patient is the backflow. When you reorganize, you put only the antegrade flow, it's very good for the patient. Doesn't matter if you fix or not the valve. In conclusion, this is the first large registry to demonstrate that TricValve system effectively reduce IVC pressure and significantly improve functional status and peripheral venous congestion at 1 year, along with a substantial reduction in hospital readmission of right heart failure. Thank you.
So, Márcio, I think we have a few minutes to discuss a little bit with the audience. If someone has to make questions or comments in Portuguese, in Spanish, or in English, no problem. But Márcio, you showed us this JAC publication with a large registry, and you showed consistent impact in hemodynamics and clinical symptoms. So it seems that the technology is effective, but do you think we need a randomized trial to compare with other tricuspid devices just to incorporate this technology in our clinical practice?
In any moment, yes. I think that at this point, what we need to understand is when start the procedure, when we need to start the treatment. The question is, why start too late? If you see the patients, most of them, almost 50% of them, were high-risk patients. So probably most of this kind of these patients, it's beyond the turning point. Yeah. So when we understand when start the treatment, I think that we need to compare. If I don't know if it's possible head-to-head, maybe not, because it's a different kind of treatment, leaflets or orthotopic implants. But we need paper support to indicate this kind of device for our patients, for sure.
Routinely.
Yeah.
Adolfo?
I am happy to see that this information coming is consistent, and you see that the right ventricle, yes, the cardiac right ventricle and right atrium decrease in size, in volume, which was something unexpected, at least for me. But then you understand that the system is working properly. The heart is working better than before, so it logic that it decrease its size. And also, it is important to see that the pressures decrease, the symptoms of the patient decrease. So the concept works. It's helping the patients, and I think that we have room for all the devices, and particularly these devices. I think that probably is going to be a solution for these patients that are very sick. Maybe as a bridge of something, why not? Or as a destination therapy, because it works. And the acute failure that we suffer with the valves replacement and the TEER is much less. So it's really seen in this type of procedure to see a right ventricle failure in acute. No?
Yes, and Matthew showed us the independent predictor of mortality, chronic kidney disease, right ventricular dysfunction, severe right ventricular dysfunction. So
yes, and when you talk about right ventricle disease, we're talking about uncoupling PA-RV.
yeah,
If you have, because when you say I have RV dysfunction, but how dysfunction is to not tolerate a procedure in the tricuspid valve? You need to understand there is a system. There is a correlation between the RV, pulmonary artery, and the left side of the heart. It's colligated. It's correlated.
It's one heart.
It's one heart. It's not two hearts, the right and the left. And if it's true, you cannot do the procedure. But I think that the most important is to understand that we have a solution. And it was very interesting here in Latin America because until this year, we had only
TricValve.
heterotopic solution,
Yeah.
TricValve. Then we had time to see what happened with our patient.
Yeah.
And what I say is, the screening failure is too high for other device. So everybody's saying, now we have the TT or we have the orthotopic solution. Nobody will do heterotopic solution, TricValve anymore. I don't think so. Yes. Because the anatomic suitability is easier for TricValve than the other device. And it works, as Adolfo said. And we saw this in our patients. We have a lot of patients in my institution, and we are following them. It's impressive.
The
impact in ascites, in edema. So it works effectively. It's good to see that you have a good solution, easier, and now you can do free contrast.
It's absolutely zero contrast and zero injury for the patient. You are not working on the heart. With local anesthesia, the patient don't care about the small movement that you do when you are working. So the procedure is perfectly tolerated. Half an hour after the procedure, the patient can be with the family. You can start adapt the medication because the heart has changed. So you have to change the medication and to adapt. I think that this is a good solution and it works again.
So we have to end the session, and I think we have to consider all this: the simplicity of the procedure, if the RV function is borderline, and all this what we discussed here. And we have more data, randomized data, but the registry show us RV remodeling, so and improvement in quality of life. So we have this technology. Is here in Brazil and in Latin America we have is the technology for tricuspid, which we have more experience. So it's a good technology. Let's see the data and goes. Final comments, Adolfo, Márcio. Okay. So thank you very much.